over the spirometry, make sure that makes sense to you because you're turning that in Thursday. And we could do review for the exam if you'd like to do it. Let me make sure I have chat open so you can see what people say. And I will be posting any advice on that last essay and today. So while you guys are working on lab, I'll put that up. So you'll have all of the comments I've made previous semesters on all of the essays for this test. So once again, just like last time, you will be receiving an email during the time you're sitting the Canvas test. And I'm not giving everybody the same essay, but you're going to be turning in an essay that day. So there's a lot to be done between now and the Thursday, 5 o'clock. So hopefully you're not too far behind, but at any point you need to go out and finish your histology drawings, you're welcome to do that too, because those need to be turned in by 5 o'clock today. Okay, so why don't you put into chat, everybody just put whatever they'd like to do as far as the review, and I'm not holding you here unless you'd like to do the spirometry first, so then you can go off and work on your histology slides. I can also do it that way instead of the review first. So just put what you'd like to do into chat since spirometry. Lots of people want to do the spirometry first. Okay. Let me open that document. Okay. So how about if I give you another minute to put anything in, and some specific requests are coming in, so. Okay, so why don't we do the spirometry first? I'll go ahead and share that. Should be up there. And if you have questions about it, let me open chat too. Specific questions about the spirometry review, because I did walk through this a bit. Is it this handout that is the issue? If it is, I mean, clearly you have to fill this out. And I think I even have my version of it filled out over here. You're filling this out from the data, but also understanding what these volumes are and their relationships to each other, and how a capacity is a combination of volumes. That would be important for both more for the lab practical than the exam as far as calculating or knowing how to do these things. But there is that one essay, which is essay 4, that brings up these volumes and capacities and understanding what they are. So chat I'll move you guys over here so we can see if there's anything specific. So I did walk through this, and maybe after you've watched the videos, hopefully you have watched the videos, this will make more sense to you. One thing I want to stress is spirometry is not it's not like taking somebody's blood pressure or their blood pH or something and that, sometimes that is already diagnostic of some feature. This is more supportive evidence of it, partly because, as I mentioned, some diseases transition from being more obstructive than restrictive. So to make it easy, more black and white for you guys, I just defined obstructive diseases, not incorrectly, as diseases that limit the flow to get to the respiratory zone, the flow through the conducting zone, versus restrictive diseases where you have limited respiratory zone. So less area for exchange that's active. Now, some diseases progress from one to the other, and others, like, say, asthma, are purely an obstructive disease, not a restrictive disease. So there were some examples of those diseases. I would know a few examples of those diseases. Okay, and then mostly this is focusing on how you could tell the difference using a spirometer, and it's showing you that if you have a restrictive disease, the total lung capacity, which includes the residual volume, that is the amount of air that's in the respiratory zone after you've fully exhaled maximally as much as you can, has decreased. Whereas the opposite sort of occurs in a obstructive disease, where you have this large amount of air that it cannot easily be ventilated and remains in the residual volume after a maximal exhale because you're unable to ventilate it. And often these people with severe asthma have these big barrel chests where they actually have larger chest capacity, but their other volumes are not that affected, whereas here you see a decrease in both inspiratory capacity and the residual volume, thus decreasing total lung capacity. Here you may see normal total lung capacity or increased if it's severe, significantly increased. But the big difference with obstructive diseases is how much you can breathe out, how rapidly you can breathe out air in 1 second, and that's that FEV1. Are there any questions on that really brief recap, since you wanted to do the spirometry? Okay, so how about, I won't go through Kevin's values because that's kind of the problem you're going to take. How about if we put some values in here? Somebody tell me the normal tidal volume value that you're given on page 546 for a man. 500, okay. And the inspiratory capacity, 3,600, great. And that is, that's equal to the inspiratory reserve, which is not on here, and plus the tidal volume, right? So therefore, it would be 500 is the tidal volume, so 3,100, oops, sorry, plus 500. Oops, I can't type again. Okay, so a capacity is a combination of volumes. Make sure that's clear. Okay, so that was what I just did, the 3,100, right? Forced vital capacity is all the movable air. So that's going to include the expiratory reserve volume, and somebody give me that number. Same as vital capacity, okay. All right, so that equals the 3,100, which was the inspiratory reserve volume, plus the tidal volume, oops, 500, 3,600. So that means, again, I can't type, that means that 3,600, well, let's do the math, 4,800 equals minus 3,600, that this must be 1,200 for the ERV. So if I pulled that out again, that would be IRV plus tidal volume plus ERV. Are we okay with these? So that's what I mean by know the relationship. Again, this is more in the lab, but it could, I suppose it could be a small amount in the lecture that I would ask you to calculate something or know what something is. All right, we're all right with that. Did I put 50? So, oh, sorry, 500. Thank you. Okay, so now we're assuming 12 breaths per minute. So that equals 12 breaths per minute. And if you multiply that times the tidal volume of 500 mLs per breath, what do you get for an MRV?
6,000.
6,000. Great. Milliliters per minute. And I know this is where the book showed 10,000 in that table, but that's only so that the math would be easier because they used a high respiratory. I know normal is 12 to 15 breaths per minute. That's a normal range for an adult. It does change with age. So, all right. So just from the table, what is the residual volume? Anyone? It was 1,200. Okay, great. Someone put it in there. So if you're talking about the residual volume, you're talking about what's left in the alveoli plus what's left in the conducting zone. So most of it's left in the conducting zone. So this equals the respiratory zone, air, plus the dead space, which is in the conducting zone. If we assume the man's 150 pounds, here I used a different number for Kevin, then the dead space is 150 mLs. So that means the estimated residual, well, the part that thus, I'll put thus in the respiratory zone, you normally have about 1050 mLs. That means when you stop breathing, if you would hold your breath, it's depleted for oxygen, but it's not zero oxygen. So you can extract more oxygen from that in theory, as long as it's in the respiratory zone. Okay, what about total lung capacity? This is going to be equal to your vital capacity plus your residual volume. So what does that equal?
6,000.
Yep. All right, so those numbers you should know. And then right in here, I'm not going to put them in here because you were meant to do that, what you've got for Kevin. Okay, when we come down here, again, you're getting this right off the table that Kevin shows you at the end of the video. But if I put in, he got 69% here and he got 52%. So why does that drop? What would be a good reason for why you see he still maybe expels the same volume of air, but in less time? What is that telling you? Anyone can just put it in chat or say it. His FEV1 has dropped. Why is that? Okay, imagine his, respiratory passageways as being wide open. Be pretty easy for air to get through as he's expelling it out. Now, let's narrow it down quite a bit with an obstructive disease. It's just harder to get, you could think of it as a traffic jam or something. It's just harder to get the same amount of air out in the same amount of time. Now, if you give it enough time, just like a traffic jam, it's going to clear. you're going to empty out the parking lot at a concert or something. You could think of it like that. You go to a concert, there's a huge parking lot, and you're only one exit road. So getting it out takes more time, but eventually it will come out. It just takes more time for it to do it. That's key to an obstructive disease. Exactly. Someone said it's obstructed. Okay, so you're turning this in with his numbers. So make sure you watch the videos. Were there any questions on the videos that go along with this? I think they do a pretty good job of explaining these things. Okay. All right. So are there any other questions on the spirometry? Can you calculate? Yeah, no. Just a second, I'll answer somebody's questions. Okay. All right, so I'm getting a few other requests I think I'm getting a woodpecker knocking on my window. A few specific requests for essay reviews. I got some pretty low numbers from Kevin's data. Is this correct? Probably the one that is really low in what I got was his inspiratory capacity. So compared, when Kevin isn't, I think most of these numbers are based on somebody who's like 6 foot tall, and Kevin isn't a huge person. So some of them would be low, but I will agree that his inspiratory capacity number just didn't come out very high. Sorry, you see what's going on. Oh, I should have known. It's not a woodpecker, it's a blue jay. And I think part of that was the drift he was getting as he was measuring. So I noticed that in what happened last year is that at some point it kind of flattened out at the top because the machine stopped being able to pick things up. It has a certain range it's sensitive, and you're trying to set that with the early calibration. But he still managed, I think, to saturate it outside that range. So it may have been abnormally low, not because there's anything with him. Otherwise, I think the lower numbers are largely because he's a smaller person. He's not, what is he, maybe 5'7" or 5'8"? So he may just not be that big a person as the numbers that they're using for the textbook. Okay, let's see what else. Explain pathologically could decrease the effectiveness of ventilation. Okay, so a pneumothorax would, because would be not a good example of a COPD or a obstructive disease. Here, your lung is collapsed, so you're actually getting less respiratory surface. You can't ventilate, but you also, there's air has been pushed out because things have collapsed. So I wouldn't use pneumothorax as an example for anything. COPD is not telling you a disease. It's just saying there's some sort of chronic obstructive disease going on. An example we gave was emphysema in the slides. And so what happens in emphysema, at least early on, is those elastic fibers that are around the alveoli are an inflammation that's going on in the lungs, are thickening the fluid and causing it harder for the alveoli to collapse down when you exhale. So they actually have more problem exhaling initially and getting as much out. Because they can't get as much out, the residual volume that's left behind tends to get bigger. And that means less air can come in, and ventilation overall is decreased. Now, as emphysema progresses, sometimes the alveoli eventually are replaced totally with scar tissue, and you're not having a respiratory surface at all, and it becomes restrictive. But the picture you have of the emphysema in your slides that you're drawing for today, what you're seeing are enlarged alveoli. They're not able to get as much out of their lung. Therefore, there's a greater amount left behind. They still try and inhale more in, and they're often using accessory muscles, because if they did a normal inhalation, they'd be less able to get as much air in. So they start breathing with some of their accessory muscles, forced inspiration, making those alveoli accept more, and then the alveoli look enlarged, and that's what you're seeing in the slide.
So, Professor, can the COPD be related to restrictive disease?
Eventually, it may transition into one. So, another example of a chronic obstructive disease would be pulmonary fibrosis. In this handout, they're showing you a late-stage pulmonary fibrosis where the respiratory tissue of the alveoli are replaced by scar tissue and therefore no longer a respiratory surface. But similar to emphysema, if there's fibrosis going on, you're adding collagen, so even though the elastic fibers may be there, they're less able to exhale, and then it would be it's considered a obstructive disease early on. My dad actually had this, so I kind of know. So initially, you are again having a difficulty exhaling. It's obstructive, but eventually, pulmonary fibrosis tends to transition into a restrictive disease, and you just get so much scar tissue, replacing lung tissue. Is that what you're asking, Kelsey?
Yes. So if you ask, like, if I understand this, emphysema or the COPD, emphysema is the example of COPD, right? One of the examples.
One of the examples, although both of those examples transition one to the other. If you wanted a strictly obstructive disease, I would pick probably asthma.
Okay.
Because there you're getting both mucus along the mucous membranes of the conducting zone, and you're getting constriction because histamine release tends to cause bronchoconstriction. You're not really affecting the lung surface at all. If you wanted a strictly restrictive disease, you could pick lung cancer, because clearly then you've not done anything to the bronchi at this point. You're replacing the alveolar tissue with tumor. So if you wanted some black and white examples, you could just go there. It's just the slide shows emphysema, and that one, at the state we're looking at it, is still a restrictive disease, but eventually you see scar tissue instead of lung tissue, and then it becomes a restrictive disease. Does that answer?
Yes. So in that case, the tidal volume, FRV, and all this will be decreased, right?
No, generally most of these conditions don't affect tidal volume, because you rarely use in relaxed breathing, you rarely use all your lung capacity that you have, right? You're not expanding the chest that much. So in both restrictive and obstructive diseases, until their blood CO2 levels rise to trigger it, tidal volume generally is not affected.
Okay.
The residual volume, the functional residual volume you saw, that's this guy, FRV. You can see it's affected, dramatically increasing in the obstructive,
decreasing,
and actually decreasing in the restrictive. Vital capacity tends to increase. Vital capacity tends to not be changed so much in the obstructive, because you're adding these together. So if you were to, I'm sure this is artificial, but if you were to measure the gray area and the red area, they'd be similar here. It's mostly the residual volume that's affected, but it's decreased in obstructive and restrictive diseases. And then you see total lung capacities clearly decreased here,
Yes.
and increased there.
Yes.
Okay.
I got it. Thank you. Got it.
All right. Is there anything else on spirometry before we go to these other chat requests that I got earlier? Okay. So some people are asking about, we find the ones, SA4. Relate this to SA4 question. That's a good one to start with because, okay, so really the biggest part of SA4 is talking about what is happening to the pressure relationships, the P atmospheric, P pulmonary, and PIP. So I would go back to the figures that you are looking at for relaxed breathing, and what is UC level for P atmosphere, and then what is the small, tiny pressure change, the 1 millimeter of mercury pressure change between P atmosphere and P pulmonary that allows 500 mLs to come in and go out. Also note how PIP, the interpleural pressure, is related to that. So that's probably the biggest part. And use Boyle's law as you do this. So you'll talk about the volume changes with relaxed breathing is what they show. Now, once you go to increase those volume changes, say you want to do a forced inhalation, you're going to see even more dramatic changes. Now, one of the things I didn't really bring up, but is something, if you think about it, makes sense. Let's say your lung is here and your chest wall's here, and this is that very, very narrow space filled with interpleural fluid, and that's gluing the lung with surface tension. I'm going to make it look a little wider so you can see. Let me just look at myself here. When you go to inhale, this is pulling this out, and if you inhale a lot more, often this narrows the space even more. So you saw that because of the PIP was sometimes -4, sometimes -6 compared to the P atmospheric or the P pulmonary. So, as you're breathing, it's following, but you can really squeeze that interpleural space tight depending on how forcefully you're moving the air in. I don't know if it's a small point, but so there's Boyle's law. Now, describe the roles of the respiratory tract, as I mentioned before. You can be very brief with that part. And really, the other big part of this are factors that affect the rate and effectiveness of ventilation. So there were some normal kinds of factors that were part of the discussion of the P pulmonary, PIP, things like surface tension in the alveoli, fluids, and in the interpleural fluids, the rebounding forces, the elasticity of the alveoli. But there are also some things the book brought up that I don't think show up in the lecture questions that well, which is things like what happens if your chest wall is abnormally shaped. So you have a hunchback or something, so that the meeting of the visceral and parietal pleura is not smooth. What happens if you have paralysis of some of your chest wall muscles? I think there were some abnormal ones in the book that they bring up that would affect the ability of your chest wall and lung to follow each other. And the idea that pneumothorax could result if you disrupt those forces. So, for example, if you have some people with really narrow chests, tall people with kind of a narrower chest, and actually my brother-in-law is one of these people, they end up, for reasons that have no good explanation other than their morphology, their shape, with spontaneous pneumothoraxes. So he's had a bunch of them, and they actually had to go in and cause scar tissue to form between his visceral and parietal pleura to prevent more of them from happening. But things like hunchback, that can lead to that, or having pleurisy where you get a lot of fluid in there. So that's kind of what I'd focus on for 4. So let's see, explain pathology that would decrease.
You already did.
Oh, you already answered that. Okay.
Thank you.
Does that do 4 pretty well? Okay. So there was the only other review was for a specific question in the sample exam. So let's take a look at the sample exam, which I think I opened here as well. Let me get rid of this so I don't have so many windows. Don't save those. Here it is. And let me find the questions in question. I think it's multiple choice question 4. Is that what you said? No, 16 and 25 was lecture. 16 and 25. Okay, so we'll share the screen with this on it now. All right, so 16, lymph nodes MALT. Is this the right 16? I want to make sure this is the one I posted. Everything good? Is it?
Yes.
Yes, okay. Lymph nodes MALT and spleen filter lymph using reticular connective tissues embedded with macrophages. So in case you haven't tried it yet, you're supposed to correct these statements. They're all false. So there's something false about this. What do lymph nodes filter? Do they filter lymph? That would be the first part of this. Do they filter lymph? Yes, they do, right? That's by nature. The lymph is traveling through the lymphatic vessels, go through these lymph nodes. MALT does not filter lymph. It's not called lymph until it gets into the lymphatic vessels. MALT is filtering interstitial fluid. Before, then maybe eventually that interstitial fluid with B cells forming plasma cells and antibodies, maybe those pathogens will get into the lymph, but this is before it gets into the lymph. And then the spleen doesn't filter lymph either. It filters, hopefully this is more obvious, it filters blood, right? So if you wanted to write, if this was, which we won't have, I think I've tried these, and I may try them again on your test, but at this point I'm trying to stick with similar formatted questions. You would write, you could just X out MALT and spleen. That would make this a correct answer. Or you could write MALT filters interstitial fluid, not lymph, and spleen filters blood, not lymph. Using reticular connective tissues, all of them are reticular connective tissues, and they have macrophages and lymphocytes inside them. Okay, the rest of it's right. What was the other question you wanted to do? 25, was that it? Let me see the chat again. It looks like there might be a new chat. Yeah, 25. Three factors that affect, well, we didn't talk about cystic fibrosis. So this would be an unfair question to ask you. Cystic fibrosis is a genetic condition, and there's a problem with fluid exchange, so that not just in your lungs, but other places, but they end up having this thick mucus that goes through their conducting zone. So all through the conducting zone, instead of a thin layer of mucus, it's a thick mucus that's hard for them to expel. So what would happen to the resistance to airflow through their passageways is, as they're trying to breathe, if your passageways now have a thick layer of mucus, it's a smaller diameter, Plus mucus is more bumpy or whatever. You're not talking about like endothelial cells lining it. It's more resistance because it's, passing by this thick fluid. And therefore, it's harder to move air in and out. Resistance goes up, diameter. So what is a third factor that affects their, I'm doing this off the top of my head, but my guess is I was getting to the fact that eventually what happens is they get scar tissue. They get a lot of infections is what happens in these patients. And those infections affect not just the bronchitis, which they can get, but they get a pneumonia a lot, and the pneumonia eventually causes a chronic inflammation. They have often they're getting these chronic bacterial pneumonia infections. So sort of like in emphysema, if you have chronic inflammation in tissues, you end up with the fibrosis, like we talked about with the COPD type of pulmonary fibrosis. And that means that the elastic fibers in their lungs are not as able to rebound because there's scar tissue there. So kind of like in emphysema, it's harder for them to expel air. And these patients also eventually, they often die from not loss of becoming a restrictive disease, but the chronic infections that they get in their lungs from pneumonia. It gets harder and harder to expel air and expel the fluids, and they end up dying of pneumonias. So what was that long list? Well, I said decreased in elasticity in the alveoli, decreased diameter on the respiratory or the conducting zone in the bronchi and bronchioli, and thickening of the mucus, which makes not just a decreased diameter, but more friction as the air is trying to go by, and therefore, and more turbulence as the air goes by, because it's not a nice smooth surface, and therefore those are factors. Okay, so I went through that pretty extensively.
2 questions, Professor.
Uh-huh.
Since you said it was unfair to ask about cystic fibrosis since we didn't cover it in lecture, that's not going to be on the test, right?
Yeah, I wouldn't specifically ask about this.
You would ask about obstructive or restrictive diseases.
But I could ask, about other, like emphysema we've talked about instead this year.
Right. So I have another question. You talked about the format, about the vid term. You said there's 4 10-point short essay questions and 4 5-point short answer questions. My question is, what are you looking for? So for my own time management, what exactly are you looking for when it comes to short answer and short essay? Are you looking for like multiple paragraphs with short essay and like bullet points with short answer, or a couple sentences?
I don't have any way you want to handle it. It's fine by me. What I would use as crudely is, one, make sure that the whole question is answered. But as long as the whole question is answered, like for example, this says 3 parts. You should make sure that there's at least 5 ideas, concepts, facts, if it's a 5.1, and at least 10. And I don't count them up.
Right. Okay.
That just gives you a kind of general idea. But I think Dr. Sundar has more, this has to be this way and this has, I don't have that at all. In fact, I think you should do whatever feels better for you. The thing I'd worry about in a 5-pointer is that they're often a piece of an essay. And what I call this the vomit response. I saw some of this on the last test where, I ask, say I ask this one, and it's only one part of the whole essay, and people just like download the essay 4 into that. So that you just start giving me everything you know about essay 4. And that means you end up spending a lot of time on this question, and it's only 5 points. I mean, essay 4, if we were in person, would be potentially a 20-point question. And I'm only asking one piece of it. So make sure you focus in on what is actually being asked and make sure you answer that part. Because the other problem I will get is as people download, they'll start answering, say they start discussing the roles of the upper respiratory tract to try and feel like that has some validity in here, which you could argue it does. But it's not directly asked for in this question. And then they get so much of that down that they just don't get to the factors that affect ventilation. And it's very hard for me to, I don't take 100% off, but let's say they spent their whole time talking about turbulence in the nasal cavity and, mucus and smooth muscle and anatomy without ever getting to diameter, how that affects it, the turbulence, how that affects it, and elasticity and the alveoli, how that, they don't get to the three factors. So make sure you read the question, make sure you answer what's really being asked, and just don't out the essays. I know it'd be nice to just download it all. Does that answer? Okay, so I've gotten a request to go through the whole sample exam. No, unfortunately, there isn't any way to allow you to see all the questions at once. I did allow you to go back and forth. First of all, it wouldn't have the space to show all the questions at once. But since you can go back and forth, you're welcome to scroll through and look at things. But I know that takes time, and I just don't have control of that.
It's just
somebody put down there is a scroll at the top that lets you click certain questions. Yes, so there's like a menu at the top. So I hope that it was a good idea. I mean, you can tell me and I can switch it around, but it would be a lot of time for me, or do it on the next test. I thought maybe if I put the longer questions first, the short answers, then you would feel like you didn't run out of time so much. Since multiple choice, if you had to, you could just guess randomly, right? You get 20% or even more in some cases chance of getting it right. So the last ones are increase, decrease, or something close to that. They look like multiple choices, but there's only three options. Increase, decrease, stays the same. Or some variation of that word, increasing, that kind of stuff. So because there could be variations, they're kind of a fill in the blank, but I didn't want you filling in the blank because if you misspell a word, it counts it wrong. So it's going to be like a multiple choice. And again, that one you could do very quickly. If you run out of time and you want to just guess on them, you can go very quickly guessing, and that way you won't leave blanks. So I thought that would be a better way of. And Noah, I agree with you that maybe the short answers are intimidating, but they should be familiar because they are really based on the essays. So if they are intimidating and you feel like doing the multiple choice first, you can just scroll down to those. Since you know how many questions there are of each type, you can just go to question 11 and then you'll be at the multiple choice first. So up to you. Okay, yes, thanks.
Seems like this test is actually longer than the last test, in that
that's because the last test had 6 10-point questions.
Okay, because it just seems like we have more written questions to deal with, and most of us, it sounded like, I know I had trouble. I didn't finish. I ended up skipping questions and not having time to go back to them, and I find this whole online process very hard anyway.
Yeah.
And taking the exams online is difficult for me. And I'm just not performing to my normal standards, my own internal standards.
Aren't we all?
And I'm afraid to just kind of drop and put it off again because it looks like we're going to be doing this again next semester.
Next spring it is going to be online. Well, I will give you a hint. Some of the short answers are list. So that means you're not writing a lot.
Well, that helps.
Yeah.
But I saw that. I saw your email last week, and I was like, I just need to drop the class.
Yeah. No. They're ones that you're not going to have to write sentences. So be careful again with your time management. If it does say list, then you only have to write 5. If it says list 5 things that do X, then, or if it says list 5 steps in triggering a B cell, list them. If you start downloading essay, 3, that's again where you end up using a lot of time. So really, when I say something like list, I mean you only need a few words. You could say, for that, if it was essay 3, you could say B cell IgM or IgD binds its antigen. B cell puts it on the MHC. I'm only making 5, right? So you can't have every little detail because 5 is not, so then you go, the antigen is loaded onto MHC2 and becomes an antigen presenting cell. A T helper cell comes along, double recognition, co-stimulation, plasma cells are generated. There you go, 5 things. But if you download all the details in a written form, you're going to spend more than 5 points worth of time. Okay, if it says explain, make sure you give me how. What is the mechanism, if there's a mechanism, that kind of thing. That's when you want to think more about writing more. Is this helping? Let's see if there's anything else. Okay, so someone requested that we do the entire test here, which I'm happy to do. You can see it was written 8 years ago, close to 9 years ago. Well, 8 years ago since it was fall, but so you can see some of the things might have been, I may have changed how I've asked them, or even some information may have changed in this, but so I'm welcome to do that. If you feel you don't want to do this, you want to do it on your own, then go ahead. And once again, I do not post keys. I don't want to, because I like to leave the same sample questions up there semester to semester, but also because I really think if I post the key, you won't think about what's wrong with the wrong answers. And I think that's as useful as knowing what the right answer is. So if you try this between now and Thursday, I'm going to be checking my email. You can email me and say, what's the answer to this? And I will definitely answer you. Now, if you email me after 6 on Wednesday night, I'm probably not checking my email. So be aware of that. Okay, so which of the following does not directly enhance phagocytosis? So C3b is an opsonizer, right? It's an opsin. So that would directly. IgG opsonizes as well. That would directly enhance phagocytosis. IgG, as far as you know, is only a receptor on the B cells. So maybe eventually it would make IgG, but that's where the word directly starts. You have to go by best answers. These two are energy juice. I don't think I concentrated on that aspect for the gamma ones, but they will. Interleukins can cause phagocytes to become more active, more energetic in their searching for their PAMPs and also in being phagocytes. So gamma interferons is maybe not a fair one this semester, but they can do that. I'd say the other interferons would maybe be focused on a little bit more, but Anyway, which of the following uses MHC1 to, if you have questions as I'm going, just stop me or put it in the chat and I'll try and pay attention. Okay, which of the following use MHC1 to react to non-self? These don't use MHC1, they use PRRs and PAMPs, PRRs and PAMPs, PRRs, well, and PAMPs, I believe. This uses MHC1, this uses a PRR and PAMP. Hopefully that one is straightforward. So when you have edema, this is going back to probably something you've long since forgotten about because it was so long ago and so much water has gone under the bridge. Edema is where you have extra interstitial fluid. So that's going to cause higher pressure outside the lymphatic capillary and force open those mini valves. So that's going to induce the lymphatic capillaries to open, and the membrane protein cables are those membrane proteins on the endothelia of the capillary, of the lymphatic capillary, that's bound out to the extracellular matrix proteins, so that as the extracellular matrix pulls away with the swelling, you get an opening of those valves. So histamine is affecting the blood capillaries. As far as I know, it doesn't affect the lymphatic capillaries and the arterioles feeding them because it causes vasodilation. Edema occurs with diapedesis. I don't think that just doesn't make any sense. This should be pedesis. It increases with complement. That doesn't make any sense either, as far as I can tell. Okay, so hopefully we're good on that one. Lymphatic tissues include all of the following except, well, this is not a lymphatic tissue. This is certainly something that helps you clean your respiratory, but hopefully this is straightforward, I hope. Okay. Inflammation is increased by prostaglandins. Yes, this is going to that table, which hopefully I haven't had anything different in back then than I have in now, but is it increased by MHC1 expression? Well, not directly, at least. IgE definitely does, though, because it causes histamines to be released in greater amounts, and IgA doesn't do that. It's neutralizing, and it forgot what the other thing, but it doesn't cause inflammation. So A and C is correct. And I'm going a little fast here because I know you want to get through the whole test and maybe have some time to do lab. So stop me if there's something you're missing. Passive immunity triggers B cells clonal selection. No, because passive means that you don't have the antigen given to you, you have the antibodies given to you. So passive immunity does not cause clonal selection. Clonal selection would cause memory cells. If you're getting memory cells like in B, then you have active immunity. It utilizes IgG if it's passive immunity going through the placenta, and it utilizes IgA if it's passive immunity going to the through the milk with infants. So that's the correct answer. Vaccinations make memory cells. You're being given the antigen typically, so it's going to be active immunity. Okay. Which of the following aids warm moistening and filtering? Concha, and they do that numbers of ways. First of all, they're lined by pseudostratified ciliated. They have lots of mucus that's secreted along their surface. They are bumps inward that make like a labyrinth, so you've got a lot of turbulence involved in them. Same idea with the nasal hair and turbulence. They don't secrete mucus, but they cause turbulence. Mucus is full of water, so that's helping to moisten it. And mucus is sticky, So it traps things. Same ideas with saliva. So clearly all of the above. Hopefully that's easy for you guys. Okay, the pressure in the interpleural space is equal to the pressure in the alveoli. So this is saying pulmonary IP equals pulmonary pressure, pressure IP equals pressure pulmonary. And that never occurs. There's always at least -4 less for this one than that. So it's always less than the interpulmonary pressure. That's true, right? Because that's what we just said. It's always less than that. Does it aid in inspiration? Yes, because if you don't have that negative pressure in there, then your lungs won't be following your chest wall because it helps glue them. So B and C is the correct answer. So it's never above either P atmospheric, like this one's saying, or it's never equal to P pulmonary, like that one's saying. Okay, parasympathetic innervation, a smooth muscle in the bronchi. Parasympathetic means acetylcholine is released. Acetylcholine is a constrictor. So if it's going to constrict ventilation, then it's going to increase the resistance. So it affects ventilation, if anything, by making it a little harder to ventilate because resistance goes up. So it doesn't affect compliance. Compliance would have to do with surface tension, muscles being able to contract to cause your chest wall to, that's part of what SA4 is on the factors, you know, your chest wall to expand. If your chest wall is not uniform, you've broken ribs in the past, you know, that all that's going to affect compliance. And yeah, so parasympathetic, as far as I know, does not cause histamine release. So that's not right either. Okay, so the answer to this one, since I went through it quickly, is it increases resistance, number A. Okay, globins change shape to permit CO2 to bind. And that's true because that's the Haldane effect. Once the oxygen comes off, the shape of the globins relative to each other shifts, and therefore now CO2 can bind to one or more of those globins. They nearly always have 2 oxygen bound to them on average, and that's maybe a bad wording because it's really bound to the heme group that's on the globin, but that is true. So maybe I didn't stress this enough, but deoxygenated blood has, I think I did stress it, but has at least 2 oxygen bound on average when you get to the lungs. So when you mix all the deoxygenated blood under a normal person, you typically have even 3 oxygens bound on average, but that's why I said nearly always have 2, because if you're really maximally exercising, you know, they could have lost a 3rd one, but they almost never. Now, why they don't is it's the hardest ones to bind and therefore the harder ones to unbind from. Okay, do they bind H+, the globins? Yes, they do. That's the Bohr effect. When they bind the H+, the oxygen tends to unload, and that's in the tissues. Have 2 types of genes coding. They actually have more than 2 in the sense that you have fetal hemoglobin, which means the 3rd type is the fetal type. But otherwise, you have an alpha and a beta in an adult, so they do bind. I actually downloaded, I never showed you, another graph showing you fetal hemoglobin, adult hemoglobin, and myoglobin, and how oxygen can be affinities change, and therefore oxygen is easiest to go from the adult hemoglobin to the fetal, to the myoglobin, and then ultimately to the cytochromes of the electron transport chain. If I'm not making sense again, stop me. Okay, nothing's over in chat. Okay, when IgD binds its antigen, basically what happens is what's asking. It causes neutralization. No, neutralization would be IgA and IgG. It causes macrophage MHC2 antigen receptors to co-stimulate the B cell, which so when it binds its antigen, ultimately this does happen. Granted, maybe this isn't the next step though. Ultimately, the wait a second, oops. I'm sorry, this doesn't happen. I misread it in my mind. I'm causing it to. Macrophage MHC2 antigen doesn't co-stimulate the B cell at all. It co-stimulates the CD4. So that's totally nonsense. Okay. It activates complement. Nope, that's IgM and IgG. That's not true. Endocytosis occurs. So that's what occurs once it binds its antigen. Opsonization, that would be, see, this is what I mean by doing the wrong ones. Think about who would do opsonization, right? Opsonization, IgG and IgA, I believe. Okay, so as partial pressure of oxygen decreases, what happens? More gas comes out of the solution. It's easier to dissolve the gas. It's easier to breathe. More hemoglobin becomes saturated in the lungs as the partial pressure of oxygen decreases. So when PO2 happens, this is the best worded question, I have to admit. Comes out of solution. So I'm assuming that I think the thing I'm struggling with, which I could see probably you guys did back when you took this test, the partial pressure, I assume I'm meaning in the alveolar gases, but more gas would come out of solution. Or is it the blood I'm talking about here? It's easier to dissolve that gas. It's easier to breathe. Saturated in the lungs. Honestly, I'm not sure what to do with this one. Because if it's in the alveolar gases, the partial pressure of oxygen in the alveolar gases, I think it must be blood. The partial pressure in the blood of oxygen in the blood gets smaller, then more gas would come out of solution. You think it's A? More gas would come out of solution. So that would mean if this is the blood oxygen, that would be true, that more of it would come out, right? Because the gradient would be steeper. So you have less oxygen, but oxygen's going into solution. I don't know where that would make sense. Why do you think that's A, June? John?
Because decrease the PP make the gas out of the.
So we're in the lung. Are we saying we're in the lung?
I think this is the for every solution, for every gas. Don't need to happen in the lung.
The gas is going into solution when it goes from the alveolus gaseous state into the water in the alveoli. When it goes from the blood out to the gaseous state, it's not going into solution, it's coming out of solution. So this is saying more of it's coming out of solution from the blood when this decreases. Okay, so all right, I can see that happening. It's not going to dissolve because this is where I should have put in this question where we are, in the blood or in the alveoli, and that's where I'm stuck trying to make sure, since it was 8 years ago that I wrote it. It is easier to dissolve that gas. That couldn't be then. Yeah. It's easier to breathe. That wouldn't be. More hemoglobin becomes saturated in the lungs. All right, I'll go with A being the best, but that makes the assumption that this is the partial pressure of oxygen in the blood. I guess that would be the case and not in the alveolar gases.
Wait, I'm sort of confused
Sorry about
again.
that.
Why would it make gas more? Wouldn't the gradient be less steep because it's going from 80 to 40 to the tissue?
Now we're in the lungs. See, that's where the question doesn't have enough information in it. I think if gas is going in and out of solution, you have to be between the air and the liquid state. If you're out in the tissues, it's all moving. It's not dissolving. It's all moving from being bound to, it's not really considered a dissolving, I don't think, when it comes off of hemoglobin, but let's throw out that question. I think there's not enough information given here. We okay with that, everybody? You okay with that, Noah? What would you thought the answer is, Noah, on that one?
Honestly, I don't know. It's a very confusing
Because
question.
if we're out in the tissues, then are we really talking about solution? Dissolving is definitely not talking about that. Breathing, no. And this is lungs. So I can't imagine I was writing this thinking in the tissues. I think I had to have been thinking in the lungs. And this is the partial pressure of the oxygen in the blood, meaning the gradient becomes steeper between the alveolar gas and the, but I'm not even sure how then A, yeah, I don't know. I don't like A even. So let's leave that one. Maybe I'll throw it out and edit this one so it won't show up again in the future. Okay, so we did one of these. We could do the rest of them. Type 2 cells are simple squamous. Is that true? No, they are simple cuboidal. They don't secrete ACE, they secrete surfactant, and that surfactant decreases the surface tension. So if you had something like this, you could, stick with a type 2 and decreasing surface tension, or you could change this to type 1 cells, and then they would be simple squamous, they would secrete ACE, but make sure when there's two things wrong that you then wipe out, they don't decrease surface tension. So make sure you correct everything that's wrong, if you ever were to get these. And I think I tried them last semester, but found that they're a type of short answer. And so it's possible, but just be careful when you're trying to say, if they're a type of short answer, you have to write something here and make sure you correct both things that could be wrong with it. As one increases in altitude, the percentage of oxygen decreases. Well, I sure hope that's not the case. So air can freely move, oxygen can freely move within the atmosphere. So that means it's going to equilibrate any percent difference, any concentration difference. So the percentage of oxygen is the same, no matter what part of the altitude you're in. The reason it is more difficult to breathe is because the partial pressure of oxygen is a lot lower. It's harder to get it to dissolve. So this is Henry's law. Okay, active immunity generates only B memory cells, increases the speed and specificity of antibody production when re-exposed to the antigen. Well, most of this is not wrong, but the problem with it is it doesn't create only B memory cells. It also creates CD4 memory cells, and if it's an intracellular pathogen, it might create CD8 memory cells as well. So that only is wrong. So just writing, it also creates at least CD4 memory cells and T cells. You need the T cell to get the B cell to become a plasma cell. So, okay, we did this one. Majority of carbon dioxide is transported to the blood as a gas. Now that's not the case. It's 7 to 10% is a dissolved gas. Most of it is transported in the form of bicarbonate. Okay, MHC1 is used only by NK cells in the innate response to identify non-self, while MHC2 is utilized only in the adaptive to identify non-self. Well, there's so much wrong with this statement, it would be hard to start. MHC1 is used by the innate, but it's not the only way the innate uses to identify non-self. Innate also uses PRRs and PAMPs, while MHC2 and MHC1 is used in the adaptive. It's true that MHC2 is used by the B cells, but again, the only is a problem. So you could probably rewrite the second half of this by saying, just get rid of the B cell part. You could just say, while MHC1 and MHC2 is used by the adaptive response to identify non-self. Okay, we okay with this so far? Okay, so this is the table. I don't think I need to go through this. I think you've got it done for you. Now, I told you don't have to know numbers for interleukins, so don't worry about that one. You could change this if you wanted on your practicing, just get rid of the 1 and 2. I must have told them they had to know that these are the two involved in the dendritic cell to CD4 cell co-stimulation. But this, I've made it a little easier by telling you guys you could just know interleukins in a sort of holistic way, not specific ones. I think everything else we did cover here. So I say it's the table, but it's a bit of the antibodies too. So that's SA3, knowing what each of the antibodies does. Okay. So this is SA6, where we're actually using a table. And I know some of these questions, because I've done this practice exam again, you can have multiple answers, or if I remember rightly, I haven't done this in a while, obviously, but any letter can be used more than once or not at all. So the letter E is the graph shifting to the right. If it's shifting to the right, that means that you are making it easier to unload oxygen. If you're shifting it to the left, that means you're making it easier to load oxygen. So remembering that, and then this was part of internal-external respiration. I wanted you to know values. So I did my best here, hopefully. It looks like B is where you're somewhere around 75, 80% saturation. C, you're at 100% saturation. And A, I was trying to hit somewhere around 40% saturation, something like that. So the letter on the curve showing where carbon dioxide affinity to hemoglobin is at its highest. So this is where the Haldane effect would be occurring. And HBO has a lot of CO2 bound to it. So where would we be? A, B, or C? Anyone want to put an answer? So oh, here we go. A, great. We got some answers. A, right. So if hemoglobin saturation is really low in a metabolically active tissue, it'd be generating a lot of CO2, a lot of oxygen would be unbound. That's where you'd be at, would be like A. Okay. Arrow E or D, showing the effect of cooler temperatures. Which one, E or D? Where do cooler temp occur, in the lungs or in the tissues? Right, D. Thank you, Adrian. D is right. So if you're shifting this way, affinity is going up, and that occurs in the lungs. Cooler temperatures relatively speaking, are in the lungs. The letter showing the percent saturation of HB in the tissues is, once again, A, right? Because we were just talking about that. Here we are in the lungs where we're 100% saturated. This is the combined deoxygenated blood coming back to the lungs. Letter showing percent saturation of hemoglobin when hemoglobin is leaving the lungs. Well, we just said that it was going to be C. Let me roll back and forth. The letter showing where the Bohr effect is occurring, meaning when the H plus binds, it has greater ability to lose its oxygen. What letter? Or is the Bohr effect where H plus binds, decreasing affinity? A, B, or C? Nobody. We're in the tissues, right? So it'd have to be A. Okay, letter showing where internal, there's a lot of A's on this one. Internal respiration, that's in the tissues. So that's just a definition. Internal respiration is where you're moving oxygen from the blood to the tissues. External is when you're moving it from the alveolar gases into the blood. And then the last one is explain the Haldane effect using the letter on the curve where the curve shows where it's occurring and how it's altering the hemoglobin. So I wanted you to talk about, again, letter A in the tissues and how you unload the oxygen. So you're at low saturation of the hemoglobin. You don't have, you could actually even be over here. You could be having the Haldane as soon as you lose any oxygen off of it. So B or A would be fine if that was the letter used. And that would allow the globins to shift so they can now bind carbon dioxide. How are we doing on time here? Okay, we have about 15 minutes left. Okay, I think we did this. Now notice this is focused on the tissues. So you don't have to tell me about how it reverses in the lungs, because this is where this is a short answer and not a 10-point. Now, unfortunately, online, you can't just draw a picture or, formulas easily. So you might want to practice putting into words the balanced equation so that you can type that up efficiently. If you're really good and you can type up, I don't care if it says, CO and the 2 is not a subscript. I don't care about stuff like that. If that helps you type it up. But I would probably include in this the carbonic acid as an intermediary where it spontaneously breaks down, and be clear where the carbonic anhydrase acts, which is to whenever water and CO2 are, well, for in the tissues in this case, water and CO2 are being combined together to make that carbonic acid. Does this ask about the fate of the carbon dioxide and the chloride shift? It doesn't actually ask about that. It's only asking what is its role in the tissues. So I wouldn't take off if you didn't tell me that most of the bicarbonate is moved out through secondary active transport into the plasma, because it's not asking about it, and it's a 5-point question. So I'm hoping this happens. HB, okay, looks like we got that. The answer was for an earlier one. Okay, so contrast the lectin mannose to activate complement with the alternative. So compare is pretty easy. They both make C3. Contrast is you're going to use different complement subunits. You could list things here. You could say similarity. Both of them form C3. Both of them, you could just list. You don't have to write paragraphs and explain the whole thing. Both of them utilize components on the outside of the pathogen. So in the case of the lectin-mannose, they're using a sugar that's common to the exterior of cell walls or membranes that might be on the outside of the pathogen. With the alternative, they're also triggered by things that are on the outside of both our cells and pathogens, but inhibitors could prevent that spontaneous generation of C3 by, if it's our healthy cells, or inhibitors even on pathogens could block alternative pathways. So that would be 5 points worth, because we gave a couple differences. You know, if you want to count them, if I say, give me 2 differences and 3 similarities or something like that, then count them. But if there's enough understanding of these 2 pathways, now would you have to go through, you could say for a similarity, both form C3 and C3 form C3A and C3B to cause oil. That would be a lot of information, but it wouldn't give, and it would be fine if you wanted to do that, but it wouldn't give you much space to add a lot of contrast. So make sure you don't just stick with 5 points and they're all similarities with no differences. That's where you want to make sure that you give me some inkling, you know, what lectin-mannose is versus alternative. But if you gave me more similarities and fewer differences, or more differences, and you know, I don't count them if I'm not actually saying, give me 3 of these, give me 5 of those. Okay. All right, the bends. So Henry's law, when you're a diver, partial pressure of nitrogen gets high enough that you can actually force it into solution. So there you need to tell me, normally nitrogen doesn't go into solution without a higher partial pressure. When it goes into solution, it only is because of the elevated pressure of pressurized gas in the tank, plus the depth that you're diving causes greater pressure to force gases in. And then when you come up too fast, since it's not a very soluble gas, it comes out of solution and causes, you know, bubbles in your blood. If you just said that, again, this is a 5-pointer. You wouldn't have to discuss stuff like oxygen narcosis here, because I didn't ask about that. And you wouldn't have to discuss all the relative solubilities. You could just tell me the nitrogen is at normal sea level pressures, is not going to go into solution. You wouldn't have to give me every bit on that Henry's law. Would you have to tell me exactly what Henry's law says? Not if you applied it, you know, clearly here, you know, but it might be a nice thing to just have, you know, Henry's law says that that gases have different solubility constants, and if you want to dissolve something that's not very soluble, you need more pressure. What if you didn't bring up temperature? Probably wouldn't matter here. So, okay, evaluate antibody project. Okay, so here, if you were doing this in person, you could just draw graphs. You know, you could show primary response and then secondary response. And discuss that. But it does say quantitatively. So I would, if you're doing this essay, if this is an essay that you turn in, I would make sure that you use some numbers, even if they're not precise. You say 7 to 14 days to come to maximum titer. You might even see a longer lag time before you see any antibodies than you would in a secondary response. Once the antibodies generated, and we're talking about only IgG in this case with titer, it's 10,000 times more, you know, or 100,000 to 10,000 times more than the initial titer, and it lasts a lot longer. So IgG stays elevated only a few weeks in primary, and a secondary can stay that way for a few months. Okay, we talked about this one. All right, the essay, we're almost out of time. This has been changed, so you'll see this is now what essay 2. Some similarities to essay 2. So it asks you to compare, contrast MHC1 and MHC2. That table in the book should help you a lot with that part, and that's quite similar. But it says in NK, T, and B cells in ours, and there's no NK cell here. So you would have to go beyond the table a little bit, which only focuses on T and B cells, and include the NK cell in that discussion if it was your essay. Describe the sequence of events to lead to CD4 and the events required to cause CD8. So I tried to help you with this essay because I wanted to make sure that you cover double recognition and co-stimulation. What did I write? Co-activation. That's ridiculous in the actual essay. It should be co-stimulation. Sorry, in the actual essay. So meaning with the CD4, it's really pretty straightforward. We talked about the interleukin exchange. With the CD8, it's a little more complicated. So you should at least include B7 pathway and the effective interleukins. And interleukins from a CD4 with B7 would probably give you a stronger clonal selection and more cytotoxic T cells response than if you just had one. That might be nice to include in there. I know this is a tough one, the CD8, so I'm generally pretty forgiving with that one. Let's see, I just got a bell go off for some reason. Is that something else that I don't understand why that went off? Okay, phew. So are there any needs or questions? And I'm sorry we're online too. It's so much nicer to have something on paper for me as well than it is trying to grade these online. Generally, you'll see from the last one, when you turn in an essay, most people get a lot of points on turning in that essay. So I'm talking about the one you're turning in by 5 o'clock. I'm hoping you've written them all up and feel good. You're welcome. You can exchange them with each other. I don't read them before and give you feedback like I used to in the past, but I'm happy to answer a specific question about an essay if you're needing help tomorrow. And I will try and be online, not online, but answering whatever emails I get tomorrow on a timely basis. Just remember, I'm not going to probably do a lot of emails after 6 o'clock at night. So try and do this before if you can. Okay, so I am going to be here for the next lab from 1 to 2:35. If you want to go take a little bit of a break, and you're welcome to come back if you don't have a class that conflicts with that. I don't know if the people who do show up occasionally or all the time at the 1 o'clock lab are going to show up and want to go through this again. We may end up doing that. Since I haven't taken roll in this lab to know who's here. But I'm here for the next, until 3:30. So if you've got questions, let me know. Remember to turn in your histology drawings. Please check the study guide as to what you need to label on them. If it's not clear to you in some way with that study guide, then ask me about it. If it's something you don't see in the photograph very well, then clearly you don't have to label it. So, for example, if you're not seeing all of the For example, if you're not seeing the areolar connective tissue and the bronchioli to do all the layers of the mucosal membrane, you really can't see it, then I don't expect a label to be on it. You should know it's there, but if you can't see it, you can't see it. So label what you can see of those layers. Okay. Any questions from you guys, or shall I let you guys go off and have lunch and finish your drawings? Okay. Other tips for the lab test? Well, you have this slides and the model pictures. I'm generally going to pick the best view that I can find of something. So if you make a list of all the things you might have to recognize in slides, and I'm mostly referring to the respiratory system here with what I'm talking about at the moment, then go through all the pictures and try and figure out which picture asks them the best, asks that particular thing the best. Then you'll be good. And the blood cells, there's only a limited number of cells, as long as you can recognize those, and then that information that's on that table. That would be my advice on those slides. Same idea with the models. Figure out all the things you've got to recognize on the models, and then figure out which model shows whatever I'm asking the best. With spirometry, I would know the relationships between the capacities and the volumes. What else is in there? With the RID test, I'd understand that test. What is the purpose of using immunodiffusion tests in general? Because I did talk about the Ohlone. That's covered in your lab book. What else is there off the top of my head? Look at the study guide, try and use the study guide. Don't make too many assumptions. Don't make an assumption that you have, from the worst side, like you have to know every single slide and see every single structure, because clearly you can't in every picture. Because then you'll drive yourself crazy. I can't think of what else to say. There's the RID test, there's the spirometry, there is the blood. What else is in there? And then the respiratory system structures. Does this help? I hope that helps. Okay, I tried my best with the study guide to guide you with that. So the biggest challenge is probably applying the study guide to the volume of pictures of models and pictures of slides. I think probably less so with the blood, because there's just not that many pictures. We good? Okay, so the practical will be of the similar format. You'll have, as I mentioned, you'll have the time at the top, and I haven't quite finished doing it, but it's probably going to be it's probably about an hour long. It's not going to be the whole time. All right. Okay, well, I am going to let you guys go. There's just 2 minutes left, and I'll see you back at 1 o'clock. If you have questions, you could use it as an office hour, or you just want to work. Okay.